Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Hi, I'm Pam Arlotto, and welcome to this episode of the Eye of the Needle podcast. Last week, we were at Vive in Nashville, and we had an interesting conversation in the booth of Elligint Health with Chris Caramanico, the CEO. Elligint is the merger of Health DC and Virtual Health. After Chris and I talked about population health and value-based care and some of his predictions, I had a number of you reach out and ask for a basic primer on value-based care and kind of where it is today. So I'm going to spend a few minutes in part 2 of Elligint Health, Driving Value, and discuss Value-Based Care 101. I'm going to spend this episode discussing a little bit more detail around the basics of value-based care and give you an update of where it is today. So view this as Elligint Health Part 2, and we'll go through the basics of value-based care. So what is value-based care? Well, value-based care is a healthcare model, and it focuses on providing high-quality care while controlling costs. So we want to improve outcomes, reduce expenditures, and make sure that patients all have equitable access to care. It's also a little bit more complicated than that in that there are a number of payment and reimbursement models, such as CCM, RPM, TCM, and several others that provide different payment programs for doing certain activities that are built on the chassis of fee-for-service, but they're available, such as CCM, which is chronic care management. It gives providers credit for doing certain activities, and so they get reimbursed based on tracking those activities. I won't go into the weeds on that, but it's important to know that while we've tested basically hundreds of different models with CMS and commercial payers, we're still kind of in an early stage and nascent period, and that a lot of the complications, such as some of the risk models like HCC and other risk models, are still kind of being vetted and planned out. Historically, these programs have been voluntary. In the future, we anticipate regulations which will make them mandatory and therefore increase adoption. So as we go through some of these next few slides, recognize that things will change in the next few years, but at least you'll have a background as to how this all got started and some of the key components of it. So let's go through some of the words that you may hear that are part of the key principles of value-based care. We hear the word patient-centered care or whole person care. And so rather than prioritizing the work of the health system, the provider, it's really focused on what does the patient need, what are their preferences, and how do you get them more involved, engaged, and activated in their own care. Another word you hear quite a bit is population health. Population health can mean a specific generation, a disease type, say all diabetics or all patients with cardiac conditions. It also might mean a certain community like pediatrics or elderly. So there are a lot of different ways to group populations. I have a client that was in a city where there was a lot of construction going on, and literally they identified builders and contractors and those that worked in the building trades as a specific community because they had different workplace injuries than some of the other populations they cared for. But there were enough of them coming through that they needed to designate them and plan for them. Quality improvement, quality measurement, evidence-based practices, certain standards of care are very, very important. We first started out with population-based care and value-based care. A lot of the quality measurement was done manually. Most of the EHRs, and in that case, a majority of their users, now have what's called ECQMs, or electronic clinical quality measures, so that those are collected and maintained within the electronic health record. We're still kind of in a transition to get that working effectively across different systems and across interoperable systems, but we're much further along than we were even 5 years ago. We also want to look at cost effectiveness. So how are we optimizing our resources and reducing any unnecessary expense? And then who do we hold accountable for certain patients that are attributed to them, or for certain clinical interventions and the outcomes associated with them? You're going to see the use of financial incentives, both rewards and penalties, based on this accountability and performance measurement. And so ultimately, the goal is to incent the providers to prioritize value over just a volume of a service. The biggest challenge we've had in the industry is that we've hung a lot of our value-based care agreements and contracts on the old fee-for-service chassis. And we need new infrastructure, new ways of working. And part of what we're going to talk about in this presentation are some of the platforms and some of the business models that are being created to support value-based care as opposed to that fee-for-service chassis. So let's talk a little bit about long history and how this has evolved. We can go all the way back to the beginning of Medicare and Medicaid in the 60s and see some of the foundational aspects that impact our reimbursement systems. We've tried cost control with things like DRGs. We've worked on managed care in the 90s, early pay for performance incentives in the early 2000s. But things really got a big push when the Affordable Care Act was launched around 2010. We had ACOs with MSSP contracts launched in 2012, and then a variety of different reimbursement models, bundle payments, value-based purchasing metrics, goals like readmission reduction. All of those have occurred in the last 10 years. And we had meaningful use happening during that time, which incented both health systems and physician practices and other providers to adopt the use of EHRs so that we could track these things electronically. And then in 2015, we launched MACRA, which provided additional incentives around tracking, measurement, and value-based care. Medicare had a branch, or has a branch, called CMMI, which is their innovation center. And they've tested and deployed a variety of these different contracting tools, models, and reimbursement processes. And back in 2023, we began to see a huge growth in Medicare Advantage, where over half of new Medicare contracts were going on Medicare Advantage, which has some value-based care components. And then ultimately, CMS set goals that by 2030, we'll have 100% of all Medicare beneficiaries in some type of value-based care programs. And so today, at the start of 2025, we're seeing a lot of new processes, new models, as some of these occurred in 2024 are listed out on the slide. So let's look at where we are today. In 2023, about a little under a third of U.S. healthcare payments flowed through some type of downside risk contract. And a downside risk contract, it's important to understand what that is. Downside means that the provider is responsible for any type of cost overrun. So if spending exceeds an agreed upon benchmark or goal, they must pay back some of the losses. Most value-based care contracts today are still voluntary, and they're more upside risk, which basically means that if a provider has returns or positive shared savings, then they're able to share in those returns with the payer. So ultimately, if you look at, we'll talk just in a moment what the definitions of the different types of payment programs are. But if you look at all lines of business, that 1/3 that have the downside risk, and then the remaining are either still traditional fee for service or they have upside risk. And you can see the differences in distribution. You see Medicare Advantage has a lot more value-based care contracts, and Medicaid is about little over half. And then traditional Medicare, you see it's a little bit less than that. So, and commercial still kind of running behind all of them. But it's kind of good to look at how that is distributed. So these are all lines of business. So this is commercial, it's Medicare, Medicaid, et cetera. And those contracts are fully fee for service. They have no measurement, no quality, no value. It's still almost 40%. So that's that orange piece of the pie. That's still a significant part of our payment and reimbursement models or fee for service. Then category 2, which is a little bit less, but if you add 16 and 38, it's over half of contracts are fee for service, but they have some value-based purchasing or some quality measurement attached to them. So over 50% have that category. Category 3 is still built on a fee for service architecture, and they have 2 subsections. 3A, which is just the upside reward that we talked about earlier. So they get to share in that, the gains, shared savings. 3B, you typically would go in as a 3A and then move to a 3B over time. So it has both the upside rewards, but it also has downside risk. And finally, category 4, which is basically the smallest percentage of all, the one we're eventually moving to, is some type of population-based payment. They've got 3 different types. One is a condition-specific payment. Another might be a comprehensive payment for taking care of that population. And then 4C has a little bit more of a integrated finance and delivery system model. So right at 28.5% have some type of downside risk. So that's APM is an alternative payment model. So this is the majority of the market. It might vary just a little bit if we had 100% of the market. But what you see is that we still have a long way to go to move away from our fee-for-service health system. But let's talk about where the industry thinks things are going. So where do payers think the future is? What do they anticipate? They think the majority, so that 76%, think the alternative payment model activity will increase, and 0 think it's going to go backwards or down. 21% think it's going to stay about the same, and 3% just don't know. They just don't have a clue. But I think there is a fair amount of agreement that we've learned a lot, but to kind of get that next big push, it's going to be even more challenging than it's been so far. But what does it take to make this happen? I mentioned earlier that we have the challenge that we've put some of these new voluntary models on top of the fee-for-service healthcare system. We're going to have to do more to fully expand that. And what is that? First of all, you've got to have interest and readiness. So usually that means going through some type of voluntary model first, so you kind of get your feet on the ground and you can build out your capabilities. The interest of the health plans or payers in your area, and then is the government influencing? We've almost always said that whatever CMS does first, the commercial payers will follow. And I think with CMS putting that target out there of 2030, we're going to see a lot more expansion and push. We still have barriers in that a lot of providers, and that's both health systems and physician practices and other provider groups. This is still all new to them. And when they bring in patients, they don't treat those patients that have fee-for-service separately than those, or differently than those they do those with value-based care. A lot of them haven't had the numbers of patients in these value-based care contracts to really make it worth their while to change the way they work. We're beginning to see more and more patients or practices and health systems have to take on downside risk, which is when they really have to make sure they have both the competencies and capabilities. Interoperability or data sharing is challenging, and we'll get more into that in a few minutes. And then just back to a lot of them really are not interested in moving to a different payment model. So fee for service has been good for a lot of people, and so they haven't really begun to do the things that will make that shift work. So some predictions in terms of adoption, and this is from the same survey that HCP did. So will adoption of these alternative payment models, will they provide better quality of care? 96% of the respondents, and you saw earlier that was 97% of the market, do believe that the quality will be better. It's up from when the survey was done in 2022. There are a few people that still strongly disagree with that. And then will it improve care coordination? Once again, a high percentage believe it will. Will it reduce the cost and make it more affordable? 88% is still a pretty large number. And then you look at, that's a big increase from 2022 to 2023 of 9%. Do we anticipate there will be more consolidation across health systems, across providers? 31% say yes, but that's a significant lower number than the other categories, and 24% don't believe it will. And then the big question is this going to make prices higher for certain services? And 57% say no, but only 7% say it will. And that's where we see the big not sure of 36%, although there are a lot of people not sure about the consolidation as well, as you can tell. So what is required ultimately for success in value-based care, particularly as we move toward both upside and downside risk? Bottom line, it's data. And we're just truly getting to the point in recent years that we have the technology capability to really pull this off. AI is going to be a big driver of this, and some of the more sophisticated advanced analytics platforms are going to help create a full picture of the care delivered to that patient or that whole patient care, and not just look at what happened, but help us predict the future, predict what we want to have happen, and then make sure it happens. So what type of data are we talking about? This is a great survey from Oliver Wyman. Claims data is really, really important because you get to see the whole care delivered to a patient across multiple providers and health systems. We also need patient demographic data, which we've had for a lot of instances, but that data is getting stronger and stronger. We're beginning to look at complete condition profiles, so it's not just what's put in structured data, but some of the unstructured data that would come from notes and other sources. The social drivers of health, so your food, nutrition, your transportation, your housing, all of those factors, and then the performance on our quality measurements, and then ultimately behavioral factors. All of these really, really do contribute to having a full picture of that patient. Historically, we focused just on the clinical data that was in EHRs, the structured data, and that's just a very, very small percentage of what really does contribute to understanding the health, both from a preventative standpoint, but also from a chronic condition management standpoint. So let's talk about, in the video with Chris, we talked about the 1.0 platform and the 2.0, just to give a little bit of background on that. What we've seen over the last 10 years is development of the 1.0 platform. And we're going to show in a few minutes what all that includes. But we're really seeing this push toward platforms so that we can enable the value-based care, and these companies can help the providers perform and improve performance in a much better way. So the challenge for providers is they expand the number of patients that are on and participating in value-based contracts. The complexity of executing on those really is a challenge. So this little innovation maturity curve from Rock Health shows things like, food as medicine, part of the social determinant strategy, or how do we cure for obesity using digital health tools. Those are all very, very, very early in their maturity. We're seeing value-based care enablement, though. We have been doing that for the last 10 years, and we're going to see that really push over that hurdle in the next few, and will become part of kind of table stakes to get this done. So what we need are some of the capabilities that we mentioned earlier, or some of the challenges. But value-based care enablement is really kind of moving beyond that, it being really early on and emerging to being one that is more mature. And we'll see this really play out in the next few years. Who's going to deliver the value-based care? Well, right now, these value-based care enabling companies are managing a significant number of Medicare lives. And you can see that's that dark blue color. And we're going to have other providers still play a big role. But I want to spend the next few minutes talking about these value-based care enabling companies. So there are the traditional business models, they're the professional service firms that all advise their customers on value-based care strategy. How do they roll out analytics? Some of them provide some contingency-based pricing models to support certain number of covered lives, et cetera. And then we see the IT systems or the digital health platform companies, like Elligint, that Chris's company is one of them. But you also see a whole variety of others as well. Most of these companies have been around at least 10 years, with some of the EHR companies taking on a much stronger role as of recent. Another business model, there are two. One is where an ACO or a different type of a company, they help the providers in the transition to value. They take responsibility for the, or they help share in the responsibility for cost and quality, but they don't own the provider asset. So the doctors still are on their own or independent or work for a health system. Then on the other side, we have risk-bearing organizations where the entities are designed from the beginning to deliver value-based care, and they assume accountability for the cost and the quality, and the clinicians often are employed or contracted with them. And then in the middle, we have some hybrids, entities that own risk-bearing delivery assets and offer value enablement services to external providers. So they do a little bit of both. The big thing that is happening is those providers that don't have partners in this area, and sometimes even in this area, may be falling behind if they don't have these capabilities, competencies, tools, and platforms. So let's talk about what these value-based care enablement companies typically have. And remember that this is from about when the ACA was launched to about 2019. And we're going to call this period 1.0. And this quote by the CNO at Memorial Health in Hollywood really says it all. 10 years ago, people didn't really understand the underpinnings of value-based care. They knew they needed EHR, and they knew they needed analytic systems, but beyond that, they hadn't really thought about it very much. But what we say is there are 5 layers of the value-based care platforms. They all are configured a little bit different, and different companies emphasize different capabilities. And interestingly, that first layer are the foundational systems. That's those EHRs. Originally, those EHRs were implemented on an entity-specific background. They really weren't deployed to a clinical integration network or to support all the caregivers that were affiliated. We're seeing a lot more integration of those EHRs, seeing more and more single instances, or at least strong data interoperability across these foundational systems. So that interoperability, that health information exchange, is the next layer, followed quickly by analytics. And originally, when these companies first got started about 10 years ago, that was doing your classic descriptive and diagnostic and kind of looking back analytics. More and more in the future, it's going to be driven by AI, doing predictive models, et cetera. Then advanced care management, where we're coordinating care, managing the transitions of care, and then supporting the consumer and engaging the patients. So part of what we focused on during this period was, how do we get started? Which program do we want to jump on board with? How we manage the new administrative burden? How do we make sure that we're using our data appropriately and doing things like closing gaps, managing referral programs, improving keepage across our organization? And then what new competencies and capabilities do we have to build if we don't have strong data literacy across our organization, or we need better visualization tools, or we need to educate the clinical team on the basics of value-based care? What are these new skills that we need to make sure we have a plan for developing? I would say there's still a lot of organizations that are still fairly immature and they might be really good at one piece of this, but not all of it. But this is the innovators really were doing this around 2015, 2016. Now what we're doing is moving to this 2.0. So if you think about the 1.0 being about experimenting and learning and building new capabilities, 2.0 is about driving performance. And the time period is right past the COVID period all the way to 2030. So if we look at this quote from Jessica Diamond, now we're in a world where we are talking about taking on full financial risk for a population. To do that successfully, you must be equipped with advanced population health management tools. And while you see the layers, the foundational systems all the way through consumer and patient engagement are pretty similar, the way they're used and their sophistication have kind of gone up to that next level. So we might have develop playbooks of how do we use the tool, what are the risk models, how do we assume the risk, how do we improve all of our processes like medication management and compliance, et cetera. All of those programs for different subgroups. So might include specialty care. Chris mentioned that they were working both in oncology and behavioral care. So those specific programs for certain population groups. Also getting a lot more sophisticated with consumer and patient engagement. Hear a lot about digital front door initiatives these days. And what we're seeing more and more and more is while someone may have their basic value-based care platform or enablement platform, they may be complementing that with certain digital health tools like AI-driven chatbots or certain mobile apps or certain community and home-based screening programs. All of that is how do we get those patients not just engaged, but activated in their own care. And then finally, how do we enable the care team? How do we leverage data to impact outcomes and give them different actions that they can take to manage these complex populations? Another thing I mentioned, we're seeing the complement of these platforms with a number of API or data-driven tools. You've probably heard me say in other sessions that we're now at a point in time where we've built the foundation, we've built the first floor, the second floor, put the roof on. Now we're kind of at this point of spackling things together. And we're using a lot of AI and workflow tools that are very niche focused to work with these platforms to make sure we're providing the best care team experience, the best patient and consumer experience. So these API-driven tools, these niche-based tools are often complementary, and they're not meant to replace the full platform, but to work in concert with it. Generative AI is playing a huge role there. This is an overview from markets, and basically, healthcare is perfect setting for these generative AI tools. It's a very data-rich environment. We have unstructured text and images that we need to get into the data set to have a full picture on that 360-degree care. And then we have a whole bunch of use cases that support patients, that support clinicians and providers, that support big pharma and life sciences companies. And there are a lot of different things that are driving the use of these. The fact that we've got workforce shortages. We are seeing increased demand as patients age for certain procedures and certain interventional and diagnostic procedures. And then we still need to reduce cost. And so it's very competitive, and AI is gaining rapid acceptance across the industry. I launched a book a few years ago. It's available at HIMSS and also on Amazon, called Orchestrating Value: Population Health in the Digital Age. And we go into a lot more detail in this book. The last few chapters, in fact, are focused on the platform and what you see within each layer, what you need, or kind of a footprint of different applications or different apps that you might need to consider as part of each layer. So I want to kind of wrap this up by focusing on some insights that we've had over the years working with our clients, and also that they may not truly be obvious, but they're really important to the overall success of value-based care. We've mentioned how important data is, but data is very complex. And a lot of people think, well, we've got our EHR, we should be fine. Well, I mentioned you don't have the unstructured data. A lot of the data quality and interoperability challenges are still out there. We also, a lot of the analytics processes are static and not dynamic. They're not looking forward. And then also that back to that unstructured data, most organizations haven't truly looked at how do we begin to incorporate that into our analytics tools and capabilities. And that's going to be a lot of the heavy lifting over the next few years. So another kind of less than obvious insight is that many providers still are heavily focused on fee for service and trying to scale to value-based care. The first few years may be very difficult as they go from upside to downside risk. They may not have the ability to take on that impact to their bottom line. And we do see some of the enablement companies coming in and providing that investment or that insurance to help them over that period of time. Attribution, that's a really interesting one. Typically, the payer, Medicare and or a commercial payer, will assign certain patients to providers. It is very much a point of friction. It's basically who owns that patient and who is responsible. And most of these models assume that the patient will behave rationally and get engaged in their own care. But compliance, engagement, and that activation challenge is really kind of front and center on making the economics of these programs work. The workforce challenges we've already mentioned, but it puts a lot more demand on the primary care physicians. And we're seeing more and more need for care coordinators and navigators, but a lot of organizations don't have the funding, the training, or even the productivity numbers of those navigators to really make it effective and impactful. And then the social determinants barrier and challenge. It's kind of the last mile of how do we deal with these things to prevent the condition from occurring, but also managing their impact. So if you have a diabetic population and there are issues around healthy food availability, food as medicine, that can be a challenge, or an elderly person that can't get to their appointment. All of those are things that must be managed by either the navigator, social services, health coach, and sometimes even the providers themselves. There are a number of systems that are trying to integrate CBO or community-based organizations with the care delivery organizations throughout communities. But the reality is health systems really don't have control over those factors. A lot of the CBOs don't have funding for these systems or the capability or knowledge of how to integrate it with the delivery system. And that's something we as an industry are going to have to kind of work through in the next few years. Another less than obvious insight is we do a lot of risk stratification today, but they're often they don't really show the stratification models don't truly show the whole picture. So they rely on things like claims data, but might miss the clinical and social risk factors. Sometimes if you over rely on these stratification methodologies, you might introduce bias. And sometimes, we're just beginning to vet the AI tools to support this effort, but we're still going to need people who really understand these things are able to work through them, and kind of the refinement and nuancing of those risk stratification approaches. Another disruption that is really starting to happen is large employers and others are fairly frustrated with the slow progress of value-based care. And we're beginning to see some Amazon, Walmart, and several others build their own models. We're also seeing new entrants, digital health companies, retail clinics, and virtual care models. They're kind of bypassing the traditional health system and trying to accelerate value-based care. But while they're doing that, they're also accelerating the fragmentation. Medicare Advantage, as I mentioned, has become a big piece, about half of the market, but we're probably going to see a little more regulatory scrutiny on that, and particularly the profit for those commercial payers that have taken on those programs. Little more look under the hood in the next few years and how those are being deployed and how they're working. Also, you know, a lot of people do value-based care to save money. The cost savings are inconsistent. And as we see rising specialty care and pharma cost, some of the original cost savings might be muted or not even in effect. So, we want to see better care coordination that will help reduce spending. But once again, it's not a practice that is always commonplace. We can guarantee this next one. While we are beginning to see a shift towards some of the mandatory models, there will be a lot of regulatory change. Providers are going to be asked to do more, to be more transparent with their data, and we will see the states pick up a bigger role in value-based care over the next few years, but that's just going to increase the fragmentation of these different programs. And then finally, the consumer will have a big role in shaping what value-based care becomes. They want their interaction with the health system to be frictionless. They want it to work like it does with other industries. They're going to demand more convenience. They're going to focus on having more care delivered in their home. And they're going to really challenge, why do I have to go to my primary care physician practice? I like this idea of a retail clinic that is close by. Amazon has integrated with Whole Foods. What if they integrate and have we begun to think about as they integrate some of their pharmaceutical or medical practices into those approaches? We'll see probably a lot more interesting business models, and we can pretty much guarantee that consumers will be influenced by their employers, particularly self-insured employers, and then direct-to-consumer digital health models that really bypass the traditional insurers and providers altogether. So, kind of to sum up these less than obvious insights, the real challenge as we move forward is designing new clinical workflows, aligning the financial incentives, and coming up with more and more integrated care delivery models that look at the whole person. So true transformation is going to require us to change the culture, the type of technologies, and the way we work with our patients. And we're going to see a lot more organizations look at new types of partnerships. And as AI gets more and more and more embedded with workflow tools and other components, how will that shape the fact that we haven't had resources that are fully skilled and experienced in this. That should make things move a lot faster. We can move some of the routine work to AI. So that's a quick summary and a quick overview. Over our next few episodes, I'm sure that we will spend more time in value-based care, but I wanted to give this little bit of an overview so that you had a sense, if you weren't familiar, at least it gives you an overview of kind of where things have been and where things are going. Thanks so much.